Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Randomized Phase III Study comparing Paclitaxel, Cisplatin, Gemcitabine, and Gemcitabine Cisplatin in patients with locally advanced or metastatic urothelial cancer without prior systemic therapy, EORTC 30987 Intergroup Study by Joaquim Bellmunt et al. It provides my perspective that considers both statistical metrics and clinical outcomes in decision-making for this difficult-to-treat disease. This JCO podcast provides observations and commentary on the JCO article, Randomized Phase III Study comparing Paclitaxel, Cisplatin, Gemcitabine, and Gemcitabine Cisplatin in patients with locally advanced or metastatic urothelial cancer without prior systemic therapy, the EORTC 30987 Intergroup Study by Dr. Bellmunt et al. My name is Mark B. Garnick, and I am Clinical Professor of Medicine at Harvard Medical School and the Beth Israel Deaconess Medical Center in Boston, Massachusetts. My oncologic specialty is urologic oncology with a special interest in prostate, bladder, and testicular cancers. And the title of my podcast is Placing the P-Value into Perspective. Does Paclitaxel add value to gemcitabine and cisplatin in advanced urothelial cancers? The keywords are advanced and metastatic urothelial cancer, chemotherapy. The authors of this manuscript should be congratulated for providing important information on the comparative use of a triplet combination, Paclitaxel, gemcitabine, and cisplatin, compared to gemcitabine and cisplatin doublet in a group of 626 patients with high-risk urothelial cancers, including those with locally advanced, metastatic, and tumors arising from the renal pelvis. The enormity of the effort is underscored by the inclusion of these patients from no less than 137 institutions, emphasizing both the scarcity of patients for clinical studies, such as this one, as well as the Herculean logistical effort to complete such studies. The work represents an evolution of an originally reported Phase I/II trial of the Spanish oncology GU group that added Paclitaxel to the standard and effective gemcitabine and cisplatin doublet that boasted, in a non-randomized fashion, a response rate of 77.6% and a median survival time of 15.6 months in 58 patients. The originally reported randomized data, triplet versus doublet, was initially reported with a median of 3.4 years of follow-up. The current version extends that to a median follow-up of 4.6 years. The trial is conceived hypothesized that the expected median survival of 14 months on GC could be extended to 18 months with the triplet program, PGC. As the results unfold, the authors yet again demonstrate the considerable complexities and failures of correctly predicting what the proper sample size and efficacy delta should be when translating data from a single-arm, small non-randomized Phase I/II study to a more encompassing and more heterogeneous Phase III population spanning different continents and practice settings. The study compared the outcomes of overall survival, defined as the time between randomization and death from any cause. Secondary endpoints included progression-free survival and the RECIST response criteria and common toxicity criteria evaluations between the doublet and triplet. The primary endpoint analysis showed, number one, a median overall survival improvement of 3.1 months in the triplet, specifically 15.8 months, versus 12.7 months median overall survival, respectively, for the triplet compared to the doublet, with a hazard ratio of 0.85 and a p-value of 0.075. Overall survival rates at 1 and 4 years of 61.4% and 17.2% in the triplet compared to 52.8% and 16.4% in the doublet. The secondary endpoint analysis showed that the median progression-free survival of the triplet was 8.3 months compared to 7.6 months for the doublet. The corresponding response rates were 55.5% and 43.6% respectively. The triplet was more toxic with a greater degree of grade 4 neutropenia, febrile neutropenia, and the need for colony-stimulating factor support compared to the doublet. The study has limitations that are important to note. First, 8% of the patients were ineligible due to improper staging or abnormalities of renal function precluding chemotherapy administration. As many authors do, there were several post hoc analyses, some which can be justified and others not. As stated above, 51 patients were ineligible post-randomization due to the disease stage and impaired renal function. An overall survival analysis was performed in the eligible, that is, excluding these patients, to receive therapy, and the results showed 15.9 months for the triplet versus 12.7 months with a p-value of 0.03. The fact that this seemingly tiny difference in this subset population compared to the original ITT population resulted in a statistically significant finding implies that the original analysis was very close to being statistically significant as well. Surprisingly, no pre-specified analyses of upper tract versus lower tract disease was undertaken. A post hoc analysis of these 81% of patients who had primary bladder cancers, overall survival in the triplet was 15.9 months versus 11.9 months in the doublet with a p-value of 0.025. No significant differences in overall survival were seen in the non-bladder primaries. It should be noted that the study population included T4B, i.e. tumor which invades the pelvic wall or abdominal wall, and N2-3, i.e. multiple regional lymph nodes in the true pelvis that included the hypogastric obturator, external iliac, and presacral regions, or to the common iliac chain, and not, notably, N1 disease, which would otherwise have designated the patient as stage 4. So what is the practicing oncologist, both general medical oncologist and urological subspecialist, to do with this data? The overall survival advantage with the triplet is not statistically significant, so should we not use the triplet and thereby save money and avoid possible toxicity? Perhaps, but I think there are some important issues here. The first is that the beauty is in the eye of the beholder. A 3-month improvement in survival may not seem a lot, but when placing this in context of prostate cancer studies, as well as other studies, it is impressive. Not as impressive as we would hope, but nonetheless there. Moreover, even with the veil of post hoc analyses, are there patient populations who could or should be considered for the triplet? In order to answer that, we should look closely at differing toxicities between the two regimens. Surprisingly, there were minimal toxicity differences between the doublet and the triplet. More thrombocytopenic bleeding with the doublet and more febrile neutropenia with the triplet. More toxic deaths on the triplet, but occurring in both. And as we have all come to unfortunately appreciate, toxic deaths are not uncommon in the management of this very devastating disease. Thus, the decision to me must weigh the slightly greater toxicity with the greater efficacy. It is unfortunate that the study was not powered to sufficiently show a 3-month overall survival advantage, in which case we may be heralding this result as a major advance. My take is that depending upon the performance status and comorbidities, I think it is totally reasonable to consider the triplet in patients who have a primary bladder urothelial cancer. Should it be standard of care? No. But given the analyses presented by Bellmunt et al. Here, and knowing the devastation of the disease, especially in the setting of a serious and advanced urothelial cancer, it is something worth considering. Again, we are generally governed by statistics, but in this case, a clinical argument based upon what I consider meaningful improvements can be reasonably be put forth to the correctly selected patients. For example, those with a prior cystectomy, no prior radiation therapy, and a good performance status. Is it worth starting another randomized clinical trial to more fully define the triplet versus the doublet? I think not. However, our community needs to encourage participation by our patients in appropriately well-designed studies to continue to improve upon the encouraging 3+ month survival advantage seen here. This concludes this JCO podcast. Thank you very much for your attention and for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.